Dear friends, introducing SICOT Pioneer, Programme of Innovative Orthopaedic Networking, E-Learning, Education and Research. What is SICOT Pioneer? A stratosphere built up of cloud and web-based infrastructure that enable communication, storage and on-demand utility of educational resource by and for our membership. The aim of the platform is to encourage cross-pollination and a virtual delivery of goals within the different pillars of the Education Academy and beyond for the global orthopaedic population. Our traits include being disruptive, global, abolishing divide, inclusive and collaborative. The SICOT Pioneer Virtual Education Programme will begin in June 2020 and consist of a variety of educational event formats that encompass all orthopaedic specialties, training, research and innovative practices.
A very good morning, good afternoon, and good evening, ladies and gentlemen. I'm Vikas Kanduja, Consultant Orthopedic Surgeon in Cambridge, UK, and the Chair of the Education Academy in SICOT. And it's a pleasure to extend a very, very warm welcome from SICOT Pioneer to all of you logging in from various corners of the world. Now, there's been a dearth of information on implants used in trauma from a holistic perspective. Yet the evolution of this branch of implants is fascinating, and this is exactly what we'd be focusing on in the webinar today. Our moderators for this session are Dr. Arindam Banerjee from India, Dr. Sasinder from Oman, and Professor Ed Harvey from Canada, along with an esteemed faculty from all across the globe. And before I hand over to our moderators, we at SICOT Pioneer strive to make every session as interactive as possible. For the global audience following this live webcast, please post in your comments and questions in the discussion box as we progress through the webinar. Our panelists will then address these questions as we go along or towards the end of the webinar in the discussion section. For those of you who are not able to join us, we have the option of on-demand viewing on our educational repository, Panopto, and we'd be happy for you to have a look at these webinars on there. Once again, a very, very warm welcome from SICOT Pioneer to all of you, and hope you enjoy the webinar. Over to our moderators.
Thank you very much, Mr. Vikas. Good day, everyone. I am Dr. Sasinder, Consultant Shoulder and Knee Surgeon from Apollo Hospital, Muscat. I welcome everyone from the International Orthopedic Fraternity to today's SICOT Pioneer Program, the evolution of orthopedic trauma implants. I thank SICOT Pioneer, Mr. Vikas, and Dr. Gao for this wonderful opportunity to host the program. I'm sure this program will be a very useful one for all the orthopedicians and trauma surgeons out there. I'll make a very short introduction of the first speaker and also the host of today's program, Dr. Arindam Banerjee. Dr. Arindam Banerjee is Senior Orthopedic and Trauma Surgeon from Kolkata, India. He is also Chairman of Education Day Committee and Vice Chair of the Education Committee of SICOT and also SICOT Diploma Examiner. I would kindly request Dr. Arindam to talk on the science, art, and commerce of orthopedic trauma. Over to Dr. Arindam.
Thank you, everyone from around the world. Today, I'm going to make the introduction to this fascinating topic of trauma implantology. We have a very interesting 5 lectures coming up, and then after that will be a panel discussion and hopefully some interesting questions. Now, in this talk, I'm going to talk about a holistic study of implants, which we will call implantology, and discuss what is an ideal implant and the evolution of implants with an example of the evolution of nails versus plates in limb fractures. Finally, we are going to discuss how trauma implants are unique from other orthopedic implants and draw our conclusions. So look at these fractures, these complex femur fractures over here. And
I'm sorry, Dr. Arvind, I'm sorry. You need
yes,
to open your PowerPoint. We are not able to see your PowerPoint.
but it says you are screen sharing.
Yes, screen share is on, but you need to click on the PowerPoint
Slide share
tab again.
Slides? No.
Yeah, can
Yes,
you hear?
you're able to see it.
Okay, good. I'm sorry about that. So we have here some complex fractures of the femur and some more of the lower limb and of the upper limb, some more fractures. And looking at these x-rays, we often wonder what implant should we choose for them, or if we have a CT scan, we might think, what is the best implant I can use? And we have all these different options, different nails, plates, Elizarov, various types of pre-contoured plates. But where do we look for this information? Do we ask a colleague in person or on WhatsApp? We can look at the internet via company brochures, or we can ask our friendly medical representative. How often do we look at orthopedic literature? Well, occasionally we look at the AO manual, but the AO is a group within orthopedics, and they have their own philosophy, they have their own theories. So they teach us their courses and their theories, but they don't cover every other aspect. Many other theories, many other groups are often ignored. So we need to have a way of looking at it in literature. And when I looked at the literature, I found my jaw actually dropped when I realized that the only time the term implantology is used is in jaw surgery when you put in artificial teeth. There's no reference to orthopedic trauma and implantology. So today we are coining a new word, and we are trying to look at this topic in isolation so that from the patterns and the trends, we are able to study the past and appreciate the current status and maybe predict the future. Now, we all know what an orthopedic implant is. It's a medical device manufactured to replace a missing joint or bone, or support a damaged bone. It is used in trauma, in arthroplasty, in tumor surgery, and occasionally in soft tissue reinforcement of ligaments. And the science of an implant is that it has to withstand different forces in a 3D model. It has to promote healing by compressing the fracture, make it heal. And while inserting, it should not damage the underlying bone. It should not damage the surrounding neurovascular structures. It should be inert, preferably MRI compatible, and these elasticities should be compatible with the bone so that there is no stress shielding. Now, over here, we can see examples in the line diagrams where various forces have been neutralized with the use of these implants. Now we come to evolution. Evolution in implant design is very important. You see, all biological creatures have evolved over millions and billions of years, either incrementally or through mutations. And some of them have become extinct for various reasons. Now, human technology does not evolve in this way. It follows a S pattern curve. So if you see here, this is the original technology. And then it comes to a point when the returns are diminishing and the new technology starts, and then it achieves its own S-shaped curve. And then it all supersedes the previous technology. But I want you to note that at one stage, the earlier technology is in fact inferior to the previous technology. This is something to note. And eventually, it is survival of the fittest. Now, the human beings have been facing a lot of challenges. The implantology has faced challenges because human beings are living longer, hence they may be more osteoporotic. Body mass index is rising. They want to return to a pre-injury level of performance and are not just happy with just union of fractures. They want to be anatomically intact and physiologically active. People are doing more sporting activity and more recreational activities, and people who have disabilities also want to lead normal lives. So implants have to rise to these challenges. And this has been helped by incremental increase in the ancillary services like radiology with the advent of the C-arm, with the advent of orthopedic furniture like traction tables, radiolucent hand tables, the improvement of metal alloys, the improvement of flexible reamers, better anesthetic techniques, regional blocks, antibiotic regimes, intensive care management, MIPO techniques, minimally invasive surgery, indirect reduction, entry point improvement. So all this has led to evolution. And if we look here, we can see the evolution of plates where we have evolved right from the round hole Sherman plates, which required very little infrastructure, but were an unstable implant and often broke, to the DCP plates, then the LCDCP, which was a better plate, and then the locking plates, which improved things even further. And over here, we have the evolution of nails, where we started with a straight K nail with no locking, and this was done in a retrograde manner, where we progressed to closed nailing, where without interlocking, and then eventually interlocking came with the advent of the flexible reamers with better C-arms, with a compatible table, and we were able to do interlocking nails as well. Now plates evolved. They moved on to pre-contoured plates, which required a little bit more infrastructure than plates for special regions, such as for the clavicle or calcaneum, plates for orthodesis, MIPO techniques, and perhaps even computer-assisted models. Nails hit back with their own improvements. They brought out the expert nails, where you had more locking options in the proximal part of the nail or in the distal part of the nail. And then nails also developed for special regions like the PFN, for distal femur, for orthodesis of joints, and even we are thinking today of computer-assisted models. So to summarize evolution, nails and plates have been competing against each other for market share, to stay relevant, to dominate the situation. Generally, nails require more infrastructure. They are the stronger implant and therefore dominate lower limbs, and because they are weight-bearing, plates dominate the upper limb, where precision is required and angular stability is important. Now, what has developed in the last 5 years, I can see, is that nails and plates are actually collaborating. They are nowadays being used simultaneously in a single fracture, where you put a plate over a nail and you get a better union rate. So that's another interesting situation, which we can see, that collaboration for survival. Now, trauma implants are unique from other implants because they help the repair process. They don't replace bone most of the time. They are like a nursemaid, which helps a child cross the road. So when the child grows up, they don't need any help, and the trauma implant becomes redundant. So there is an importance to this uniqueness. If you're comparing arthroplasty with trauma, if you have an infected arthroplasty prosthesis, infection equals to either removal or revision. Whereas in trauma, if you have an infected nail, you will try to retain the nail until union happens, provided the nail has been done well. So you can give it some time. Arthroplasty implant needs to last permanently, but a fracture implant needs to stay only till consolidation, which should not exceed 2 years. So in arthroplasty, survival rates are important. 15 years are expected, whereas in the nail, perhaps 2 years, a nail or plate, 2 years should be sufficient. And generally speaking, arthroplasty implants are more expensive because of their specifications, whereas the trauma implants prices are low, but they are rising because the specifications are increasing. So what is the future of nails and plates? I'm just talking about these two right now. Because of their shape and design, it is very unlikely that nails and plates will become extinct from traumatology, but they have been severely challenged. About 15 years or 20 years ago, they were challenged a lot by the external fixators and the Elizarov fixators. However, that threat was short-lived. In pediatric fractures, Professor Johari will tell us, TENS is now a leading way to fix fractures. And the other impending threat is from replacement surgery, where we are actually replacing bone in trauma. Well, whatever it is important to evolve. It is important to change. Custom-made implants may be the way forward. MIPO variations will continue. Computer assistance will come in. So the only thing constant in life is change. Thank you very much.
Thank you, Dr. Arindam, for a wonderful talk on the evolution of orthopedic implants. I'm sure there's a lot of evolution that is going to happen.
You become silent.
I'm sorry. Thank you very much, Dr. Arindam, for your wonderful talk on the evolution of orthopedic implants. I would like to invite Professor Shetty for the next talk. Professor Shantaram Shetty, Professor of Orthopedics and Trauma Surgeon from NITI University, Mangalore. He is past president of the Indian Orthopedic Association and is also the SICOT diploma examiner. I kindly request Professor Shetty to talk on upper limb implants, mobility without sacrificing stability. Dr. Arindam, can you stop your screen share?
Yeah, I'm trying to. Yeah, done it.
Yes.
Thank you.
Dr. Shetty, you can share your screen now.
Good evening. It's a pleasure indeed to be a part of this very important webinar. The evolution of orthopedic trauma implants, the upper limb fractures. The theme is mobility without sacrificing stability. Where are we in 2020? I greet you from my university. It was Aristotle in 350 BC said life is movement, and the AVO slogan came up only in the first part of the, in 1950s, that life is movement and movement is indeed life. Plate osteosynthesis and intermedullary nails have played a major role in this particular concept. And understanding of metals, as was stressed by Dr. Banerjee, is the boon for our progress in implantology. From iron, from copper, to even ivory pegs of yesteryears, we have indeed moved today onto perfection. With stainless steel, cobalt, chromium, molybdenum alloys, titanium alloys, and nickel titanium alloys. And the type 316L stainless steel and TI6A1, that 4V, and commercial pure titanium are currently the most popular materials used for implantation purposes, which have made our purpose easy. Coming to plate in orthopedics, from the days of Hansmans in 1896 to Lambertet, to Robert Dennis, to AVO Group in 1958, and from 2010, we have anatomical plates, especially for the upper limbs. Osteosynthesis by plate fixation has evolved to betterment, bringing about solace to the patient and to the surgeon as well. Today, we have non-metallic materials also, bioresorbable polymers, carbon fiber reinforced the polyether ketone, what we call as PEEK, for fracture fixation. From the credit of compression as a device in fixation should go to Robert Dennis of Belgium. And it was his paper in 1949, Capture of Dennis, which brought a remarkable change in the fixation of fractures, especially of the upper limb. Robert Dennis rightly said immediate active movements of muscles in the affected region and adjacent joints is important. Complete restoration of the original shape of the bone and direct union of bone fragments without formation of external callus, which we call as primary union of bone. So a new vision, Maurice Muller met Robert Dennis in 1949, which perpetuated the birth of AVO. With the evolution of AVO, rigid fixation and primary bone healing became a reality in 1950s. And the self-compression plate came into being. And today, we have plate designs evolved for the upper limb, as was told by Dr. Banerjee. From Sherman's plate, we have gone into tubular plates. From tubular plate to reconstruction plates, to DCP, to LC-DCP, to LCP. And today, we have anatomical plates fitting on to the anatomy of the particular bone for the convenience and the betterment of fixation. AVO principles, from anatomical reduction to rigid fixation to preservation of blood supply to early pain-free active mobilization. Today, gentlemen, a precarious balance is met between mechanical perfection and devascularization of the bone fragments. From absolute stability, we have gone into relative stability. We must understand compression plating needs adequate bone quality, sufficient bone supply, precise plate reshaping, and anatomical reduction. And also the risks of compression plates are large exposure to achieve absolute stability, disturbance of blood supply, and sometimes loosening of the plate screw in osteoporotic bones. So the initial enthusiasm, which was 50 years ago, today biological fixation has come into being, emphasizing the importance of periosteal blood supply, which is the mainstay for biological healing. So surgeons and researchers, developers were searching for a technology where all could be answered. LCP thus came into being with an ideal combination of two well-known anchorage concepts as a compression plate and an internal fixator. A single beam construct is created where there is no motion between the components of the beam, that is the plate, the screw, and the bone. And that's why a single bone construct is created when there is no motion between that's why the plate, screw, and the bone. A single bone construct are 4 times stronger than the load sharing beam constructs where motion occurs between the individual components of the beam construct. Additional advantage of the lock plates construct is avoidance of stress shielding, and it prevents local bone necrosis and improves the ability for resistance of infection. With this technology, LCP provides biology and LCP provides mechanics for early and undisturbed healing. Today, anatomical plates have evolved because of the different shapes of bones, especially of the upper limb. Look into each of the bone, whether it's the lower end of the humerus, or the head of the radius, or the proximal humerus, or the distal radius, or the distal humerus. You have different anatomical plates to suit to the anatomy and firm fixation. Even the new regional locking plates have come into being. With difficulty, we used to fix the lateral end of the clavicle with the K-wire. Today, we have evolved from the hook plate to the anatomical plates with 5 screws at the end of the plate to fix the distal fragment very well. Even the plate fixation up till 1970, majority of us treated fractures of the clavicle conservatively. Today, more than 30 to 40% of the fractured clavicles are treated with anatomical plates, as you see here, from anterior to it goes superiorly to fix into the anatomy of the clavicle as a bone. Coming to the AC joint as such, we used to fix it with difficulty. From suture anchors, we have gone into dog bone plates today with the pure good anchorage of the acromioclavicular joint, which always was a challenge to the treating surgeon and the patient. Look into the proximal humerus with difficult fractures of the fracture dislocations of this. From LCFP, we have gone to the philos, and from philos, we have gone into the variable angle plates today, so that the fixation is very firm and there is no loosening and the varus. And the peak plates have come in, as I mentioned, the proximal for the proximal humerus and for the tibia. Easier advantages are that it is easier to assess union in lateral view, elasticity comparable to the bone. Look into this shattered lower end of the humerus. We used to fix it with different types of plate. Today, you can with the column plates, the lateral and the medial and the olecraneal plates, any amount of shattering can be made into a perfect bone with good mobility and agility. We used to fix the bone posteriorly with the medial and lateral. Today, we have plates where lateral and medium column are well fixed and the screws go across. Coming to the radial head, many of our senior surgeons, we have thrown the head of the radius to the bucket many times. But today we have evolved with a pre-contoured plate with the anatomy with total of 9 locking options, as you see here, with a perfect fixation. Only if it cannot be solvable, then a radial displacement of the head is. Look into the conventional plate as here, which has become loose, and the distinct posterior cortex, and we have fixed it with a LCP with perfect union in 3 months' time. So LCP is a bone. Only these points of understanding the principles of locking, proper technique is required. The screw plate construct should be stable. Only if these points are kept in vision, outcome of fixation will be excellent. Coming to the last another 2 minutes on intramedullary renailing, paying tribute to this great visionary Gerard Pulsar, who said elastic impingement is possible, and the most elegant way to stabilize a diaphyseal fracture is an intermedullary nail. Unfortunately, it is not very much so in the upper limb fractures. We have evolved from what was Kuncha nail to the AO nail, up to antegrade and retrograde. The different types of nails came into being, and the different types of fixation of the proximal humerus came into being. But always a problem of impingement at the proximal end, and the possibility of shattering of the distal end came into being. And we must understand humerus is a very peculiar bone where there is a torsional effect occurring, thereby a possibility of non-union is much more. Today, we have, gentlemen, evolved with multi-lock nails for humerus, which gives both ability and stability. Looking into the entry point of this particular nail, which is much more medial, which does not impinge on the supraspinatus, and it is in direct line with the medullary cavity, and it also has a possibility of a screw inside the screw possibility, so that it is not only multiplanar, it is multi-axial. Look into this multi-lock nail. Look into our own case with the fracture shaft of the, almost at fracture dislocation with 4-part fracture, successfully treated with this nail, and you would appreciate, and it is anatomical. The arc is very well maintained, and there is no impingement whatsoever of the supraspinatus. Coming to the both bones of the forearm, I want to stress the plate is the only answer for the both bones of the forearm. Nails have no role to play in both bones of the forearm, because both bones with the proximal and the distal joint is a complex joint by itself, and any type of nails, elastic or non-elastic, except in children, it does not have a role. Well, coming to the distal radius, as you see here, many plates have evolved from the volar plates to distal type of plates to the variable angle plates today for a very good fixation, even for a hook plate for the ulna, as you see here. And this is the classical way we fix distal radius, whether it is fragment fixation, whether it's a volar plate or a dorsal plate, or a multi-lock, the multiplanar screw fixation, as you see here, where all elements of a volar tilt, the radial inclination, and the ulnar variance is very well maintained, as you see in all these cases. Well, the take-home message, gentlemen, is plate and nail evolution for upper limb fractures has been the history of perfection to bring about union of bone. With better understanding of metals, we have evolved from Sherman's plate to variable angle plates, from K nails to multi-lock nails, from irregular bone healing to primary bone healing to biological bone healing. But what is most important is the reduction of the fracture per se, and the biology and mechanics which are interdependent. This is the most important take-home message I would take. Lastly, plates and screws and nails cannot unite a fracture. The principles of fixation and safeguarding the biology is paramount. Surgeon should be a gardener and not a carpenter. Thank you.
Thank you very much, Professor Shetty, for a wonderful talk on orthopedic implantology of the upper limb, and thank you for stressing out that biology is very, very important. I would like to kindly invite Dr. Peter Beiberthaler. Professor Peter Beiberthaler is Professor and Department Chair at Technical University of Munich, Germany. He is also past President of Association of the Rational Fixation of Fractures, a sister society of SICOT. I kindly request Dr. Peter to talk on lower limb implants, strength in versatility. Over to Dr. Peter.
Thank you very much. Hello, everybody. I hope you can hear me. And I am pleased to share my screen. Can you see it? Okay.
Yes, we can see it.
Very good. So if I should talk about lower limb implants, I could talk for some days. I only have 10 minutes, so I want to focus on some very particular indications to give you this information for take-home message according to the principal jobs of orthopedic implants. So what are the jobs you should reduce the fracture, hold it, and then allow rehabilitation of the patient. And I want to draw your attention to this guy. So always, if you see complication jack, you know that there's something going wrong and somebody tried something which is not so good. This is that you keep in mind when things are not going well. Okay, complication jack always will catch you if you do things wrong. So we have many implants, and my previous speakers showed already many options. So we have increase of invasivity if you come from external fixators to wire, screws, and plate, and you have, of course, anatomically pre-shaped plates. What was then the development of plates, especially for the proximal femur? You can see here this poster from the AAOS, and somebody took a lot of effort taking together all of implants have been developed so far. So at the end, it's important that we have a clear classification. So this is from the biological point of view less complex, and then this is getting more unstable down here. So of course you need other implants. So what is the gold standard so far? The gold standard is a double screw nail. And why is it like that? Because the nails do have a biomechanical advantage, since the lever arm is much better if you have an intramedullary fixation system as compared to a plate system. So now complication jack is coming. If you try to solve A3 femur fractures, then things will go wrong if you do it with a plate. So please, this is my first important message. If you have proximal femur 3-1 type A3 fractures, don't do it with plates, because this is from the biomechanical point of view not good. How to do it right? You have the patient, here is an A2.3 fracture. What do you do with him? You put him on extension table for reduction, and after this you put in a double screw anti-rotational nail, and then you can let the patient walk on this immediately. And as we all know, those old patients, you can give them crutches as long as you want. They will walk on full weight bearing. Go to the femur shaft. Another interesting case, this guy, 29-year-old, he came from Georgia. He was big in girls, drugs, and weapons, and he broke his femur, and somebody in Georgia screwed a plate on a femur shaft. And you can imagine what happened. Of course, complication jack is coming, and this one has broken, and I personally, I'm not sure if the surgeon is still alive, but with this, the patient came to my unit, and at first we did a CT scan to be sure that this is only a mechanical problem and not an infection problem. And then we changed him to a nail, and as you can see here, nailing leads to good function, and at the end I kept my knees. So distal femur, this is a pretty complex situation where you have a joint part and you have a shaft part. So the principal strategy of treating these type of fractures is, first of all, you reduce the joint block and make out of a C-type fracture a A-type fracture. You secure this using K-wires and screw, and after this you adjust this to the shaft using one of those already depicted modern polyaxial plates. I can show you how you do it. So first you go in here, you reduce your fractures using clamps, and then you put in those modern polyaxial plates where you can adjust the screws on the top using those jigs. And this is how it looks after 3 months and after metal removal. So we go now down to the proximal tibia. The working horse for split type fractures in the proximal tibia, of course, are screws. You can tighten everything together and then secure the whole thing using plates. So I want to share this case with you. A patient after substantial proximal tibia fracture, he sustained some crucial ligament repair some years ago, so the bone was already weakened. And in this situation, he developed a compartment syndrome. So first we took care of the compartment syndrome, put an external fixator on. After compartment syndrome came down, we applied a 360 degrees strategy, which means that please, if you have these type of fractures, think where is your leading pathology, and starting from this, you plan your fixation strategy. In this case, after the soft tissue came down, as you can see here, we started from the medial aspect, reduce the joint fracture here, put the buttress plate on, and after the buttress plate was in place, as you can see here, we changed the lateral side, open up here, reduce the joint block, as you can see here, fixed it using K-wires, and after K-wire fixation, we switched in a polyaxial locking plate. And in this situation, we are very happy about this minimal invasive approach down here, because you don't want to have a big incision additional to the compartment syndrome incision. And after everything is fixed, you can slide in the plate and fix it. And this is how it looks at the end. So this picture, you can see the whole versatility of implants. So we have screws for small fragments. You have a classical buttress plate to fix the medial part, and you have a modern polyaxial locking plate. This is how it looks after 6 months, and everything came to healing. And this is 1 year after. Okay, take-home message. The first and important thing is choose your implants according to the function you want to apply on the bone. If you have complex injuries, please think about an additional plan B and a plan C, and be sure that if you go to the surgical department, you have everything on board. So if things go wrong with plan A, you have additional options. Keep away from complication jack, because everything which can go wrong will go wrong. And if you do revision of other surgeons, please don't just do the same, because there was a reason that things went wrong. So please change the implant strategy, which means the conclusions. We have a broad variety of implants for the lower limb, from external fixator until anatomical pre-shaped plates. If you treat fractures like this, think about the character of the fracture, about the biological options, and about the patient individual factions, and then choose the optimal implant. Thank you.
Thank you very much, Professor Peter. Thank you for a wonderful and crisp talk. And I'm sure lower limb failures are possibly higher, and it is definitely necessary to know what to do and what not to do. Thank you very much. I would now like to invite Professor Dr. Ashok Johari to make his talk on pediatric implants. Children are not small adults. Dr. Ashok Johari is Senior Pediatric Orthopedic Surgeon from Mumbai, India. He is also past President of the Indian Orthopedic Association and President-elect of SICOT. Over to Dr. Johari.
Well, thank you, Sasinder, and greetings to all my friends, past, present, and future, all over the world. Now, pediatric implantology, if I may call it, is very, very different from adult implantology, and there's an interesting story to start with. This is the first textbook which was written on fractures in children by the famous Walter Blount about 65 years ago, and the rules he gave, axioms that he gave us, were that children's fractures all do well with non-operative treatment, and the use of internal fixation, because conservative management fails, is the way of an impetuous surgeon. Well, traction and spike-up methods actually ruled at that time, but they involved a prolonged hospital stay. Hygiene was difficult, and there was high rate of shortening and malunion, which demanded a change. So a changing trend came in the management of pediatric long bone fractures, shifting from traction and spike-up methods to internal fixation. Also, this change was brought about because of the altered mechanism of injury. We had more and more incidents of high velocity injury. There was increased patient expectation. They would not tolerate a deformity. They would not tolerate shortening. Better technology was available which could be applied. And then keeping patients on conservative treatment in hospital actually costed a lot. There were a lot of financial pressures. So implants came about for selected fractures in the short term. In the short term, because children's fractures heal very rapidly, also your reduction need not be absolutely precise because of the powers of remodeling. What we need to do is to allow maintenance of alignment and support healing, but with minimal disturbance of biology, with minimal invasion. The fracture is very, very good for healing. I mean, it's on our side for healing. Malunion and shortening can be obviated by the use of implants, and they allow early mobilization and discharge. What implants we used are governed by the age of the patient, the weight of the patient, the type and location of fracture, the associated injuries which are present, and the experience of the surgeon. If I were to briefly go into the landmarks in pediatric chromatology or implantology, well, growth plate is important because that differentiated a child from an adult in 1750s. John Hunter described it. In 1909, Martin Kirschner described his wire for traction, but it was not until 1932 that Lau first used this K-wire for fracture fixation. Rush nailing started in 1937. Salter and Harris described fascial injuries and the importance of reduction in fascial injuries in the 1970s. Ender and Simon Widner described the condylocephalic nailing. A similar type of nailing, the elastic stable intramedullary nailing, was described by the Nancy group in the 1980s. 1990s, we had plates, locking plates also were available, and submuscular usage became predominant, and interlock nails were also available for pediatric use. In the 2000s, we have lateral entry trochanteric nails, the fascia dual nail, and the bioresorbable implants. So when we talk of evolution to 2020, we need to discuss all these areas, articular and fascial fractures, metaphyseal and metadiaphyseal fractures, diaphyseal fractures, special areas like the proximal and the distal femur, and miscellaneous fractures, those of the avulsion and small bone involvement. Now, any markedly displaced, unstable, and irreducible fracture will demand surgery, will demand implantation. Coming to articular and fascial fractures, perfect reduction is desirable to prevent growth arrest. And Martin Kirschner in 1909 described this K-wire, and that is the workhorse for managing children's fascial injuries, along with the stainless steel screw or the titanium screw, which may be cannulated or a solid screw. So K-wires and screws are used for fascial fractures, for supracondylar fracture of the humerus, medial epicondyle, olecranon fractures, proximal humerus, wrist and hand fractures, fracture neck of the femur, and avulsion fractures. Besides, K-wires are also used for provisional reduction. Now, this is a 9-year-old patient with an ankle injury. Seems very, very innocuous. But if you do a CT scan, you find that this is a Salter-Harris 4 type of injury with comminution which is present. This is fixed by a single screw. The patient doing functionally very well. After screw removal, 2 years, there is no evidence of a growth arrest. Now, proximal humerus can be fixed by K-wires, and this is sufficient in children. Elbow fractures are all fixed by K-wires. Your lateral condyle fracture can be fixed by K-wires. If your metaphyseal fragment is large, you can use a cannulated screw for fixation. Medial epicondylar fractures can be similarly fixed with K-wires or with screws. Capitellar fractures demand an accurate reduction and a good fixation by means of screws. Now, olecranon, which is basically avulsed usually in fractures, it's amenable to a tension band wiring. So you use K-wires and stainless steel wire to fix them quite well with this tension band principle. Now, similarly, screws and K-wires can be used in special areas like the proximal femur for transcervical fractures, as well as for the Delbert type 1 injury. Though a lot of plates, specific plates and customized plates are available for proximal and distal area, well, they are used as the situation demands. I'll give you an example here of a 10-year-old child with a basal fracture, basal to actually transcervical fracture. It's a little away, but toward the basal side. And surgeon fixed it with 3 cancellous screws. Well, he thought the fracture is healed. So a year later, actually, he removed those screws and the whole femoral head fell into varus collapsed. And then we had to revise it by means of a proximal femoral plate and a graded trochanteric fixation with a tension band for the relative neck lengthening, which was carried out in this case. Metaphyseal or metadiaphyseal fractures are a different sort of ball game because the fixation area is not much. So you have different types of implants which are available, right from depending on the age of the patient. One can use plates, one can use titanium elastic nails, locking screws, rush rods, and all the specialized type of plates and angle blade plates can be used in this region depending on the age and other parameters. For diaphyseal fractures, we use titanium elastic nails and locking screws. Locking plates can be used, and for special situations, we use the fascia dual rods, especially for osteogenesis imperfecta. Plates are used with all philosophy, whether it's compression, tension, neutralization, buttress, or bridging. Indications are metadiaphyseal or diaphyseal fractures, proximal femoral fixation, and for pelvic and calcaneal fractures. So length unstable diaphyseal fractures in heavy patients, in children who are less than 10 years old, because titanium nails don't become an alternative in this situation, special indication for plate fixation, and polytrauma may depend plate fixation. So this is a 15-year-old patient with cerebral palsy with bilateral recurvatum osteotomies. 1 year before he had this fall, and he had a shattering injury which was displaced, and that required plate fixation with multiple areas of fixation and screw fixation. Metaphyseal fracture, lower end of humerus, can be fixed similarly by plates and screws. Titanium elastic nails can be used for long bone diaphyseal and metaphyseal fractures. They're also useful for radial neck fractures and for clavicle fractures. They're available from 2 to 4 millimeter in diameter. The length can be cut intraoperatively. The nail tip is bent in a smooth bend. They work on the principle of 3-point fixation and elasticity. Because of the rebound phenomenon, there is some sort of a locking, elastic locking, and that gives rise to axial stability, flexural stability, translational stability, and rotational stability. Advantages: small scar, early mobilization, short hospitalization, no cast, and better hygiene. But in unstable fractures, it can give rise to loss of fixation and nail migration with angular deformity and shortening. The ideal patient is between 6 and 12 years of age with less than 50 kilograms of body weight. So this is a maluniting fracture, delayed union of a fracture femur, treated with elastic stable intramedullary nailing, and after the nail removal 1 year later. Humeral shaft fractures can be treated by Essen technique. Forearm fractures also can be treated by similar techniques. Radial neck fracture is a special indication where actually the radial head is reduced by turning or rotating the nail to get it into a proper alignment. Interlock nailing is indicated for unstable fractures in adolescents, and one example here. So the take home, today there is a trend for more invasive treatment. That's understandable because we have more high energy fractures. We have failures of non-operative treatment. Implants simplify patient care. There are psychological, social, and financial reasons for the use. And we have improved operative techniques with very, very low morbidity. Which fractures we fix? Fractures of necessity, femoral neck fractures, lateral condyle fractures, epiphyseal injuries, Salter-Harris type 3 and 4, intra-articular fractures, and Galeazzi-Monteja injuries are fractures of necessity. Other fractures which can be fixed are fractures with associated injuries like post-reduction nerve injury, arterial injury, compartment syndrome, compound fractures, unstable fractures obviously, and multiple injuries or polytrauma may need fixation in these cases. So thank you very much. Have we resolved our controversy? Are we as orthopedic surgeons becoming more reckless, or are we producing better results with our increase in surgical intervention in the management of children's fractures? I leave that to you to decide. You have the answer, don't you? Thank you. And thanks to all this group for helping me with this presentation.
Thank you very much, Dr. Ashok Johari. I'm sure pediatric orthopedic implantology or traumatology is a very, very vast topic that can be completed in 7 minutes, and there's lots and lots of controversy. Thank you for covering up on most of them. And I'd like to kindly request Dr. Christian Lozano to make us talk on moving targets and changing goalposts in trauma implants. Dr. Lozano is consultant orthopedic surgeon from Clinica Anglo-Americana, Lima, Peru. He is chairperson of AO Trauma Peru and faculty of AO Trauma and SICOT, and is also member of the education committee of SICOT and the Peruvian national delegate for SICOT. Over to Dr. Lozano.
Thank you, Ceci, and for the committee for the invitation. Well, I will talk about the moving target and changing goalposts for the trauma implants. So as we know, fracture heal without treatment, and that's why doctors have successfully treated fracture for a long time ago. So But if we remember 70 years ago, non-operative and operative fracture treatment were highly unsatisfactory, and we can see no unions, malunions, and a lot of soft tissue problems. So George Perkin told us that most disability that occur following fracture is related to the treatment and not to the pathology. So that's what he called fracture disease. But fracture disease, what does it mean? And it means stiffness, muscle atrophy, skin atrophy, and circulatory dysfunction. So that was the main problem with the treatment of fractures a long time ago. So what was the problem with that? That the poor outcomes from operative treatment was a lot of failures, and they were because lack of adequate instrumentation, failure to understand fracture healing and how the soft tissue works, and poor training of junior doctors. So if we can see that operative treatment is worse than non-operative treatment, but Robert Downey changed the history, as we learned in a few talks we hear in a few past minutes, and Maurice Muller contribute with his development of the treatment of fracture after he met Robert Downey in Belgium in 1950. So the AO's history or story is his story of a group of surgeons who committed themselves to achieve better outcomes in the treatment of fractures. The AO surgical principles were anatomic reduction, rigid fixation, preservation of soft tissue, and early active mobilization. But the AO value concept that we have to keep in mind is that the clinicians define the clinical problem, research lab does basic research, development lab design new implant and technique. Now the manufacturers make the new implant and the clinicians test the new implant and test the new technique. And after that, the clinicians teach the new technique. That's the AO value concept. Keep in mind this. So the AO organization have, as we can see, 4 pillars, and they are research, development, documentation, and teaching. So as we can see, the plate design has an evolution, and this evolution minimizes the detrimental effects on the bone. As we can see in the picture, we had the DCP plate, the low contact or limited contact DCP plate, and finally the PC fixed plate. And right now we have the locking and variable locking plating, and they are very important for us in the treatment of fracture. But the main indication for this type of implants right now is osteopenia, osteoporosis, metaphyseal comminution or short metaphyseal fragment, periprosthetic fracture, and some special circumstances like an early unprotected white bearing, osteotomies, and minimally invasive surgery. The plate function, same plate can have different biomechanical functions, but what will not change in the future? The objectives of the fracture treatment. And what are they? That we have to have good results and less complication. Good results, fracture healing, reestablish the anatomy, regain function as fast as possible, and less complication, less mortality, less non-union, less malunion, and less infections. So the main source of fracture, we have 2 populations right now. Population with high energy trauma fractures and population with fragility fractures. And in high energy fracture, we have a lot of disability, time out of work, unemployment. And in fragility fracture, we have dependency, non-ambulatory, and high mortality. We can see that these fracture, they are good examples of high energy fracture and fragility fractures. And that's the main population we have now to treat. So fractures in elderly patients, fragility fractures, it's a problem, but what's the dimension of the problem? That usually we have, in some cases, bad outcomes, high readmission rates, increasing incidence of osteoporotic fractures, and high refracture rates. So, but the dimension of the problem is that we have results that surgeons would never accept in younger patients, high revision and complication rates, and increasing demands of elderly people. But what motivates us to develop a new technology? Quality of life, as we can see in the picture. And what are the trends? Union progression monitoring, as you can see, smart socks, flexible interface, pressure sensors, smart implants, that monitoring of implant loading, load sharing with bones. Smart implants like the early detection of healing disturbances, as you can see in the picture. Adaptive implants, they are biphasic plate, as you can see, this new type of plate. Hybrid bone graft, induction of basal within artificial bone substitute, autogenous cells, and biodegradable scaffold under biological stimulation. Some polymers, like matrix, that they deliver cells and biological factors, high-porous 3D structures, biodegradable materials, like scaffolds, they don't require to remove them, and biodegradable implants, hardware removal unnecessary, polymer stiffness reduced as solid hardness, possible use as carrier of antibiotics and healing stimulants, some different implant surfaces, as you can see, and the implant surface treatment to change energy, lower and higher, and potential to change biofilm formation. Nanotechnology is the future. Develop of bioactive, biomimetic, and biodegradable materials that they stimulate cells and biological process in a controlled manner, and some adhesive for small fracture fixation. Some adhesive, they are not developed at this time, but it will be the future. Cyanacrylate and fibrin will be a very interesting field to develop in the next years. Some stem cells will learn a lot of them in the last years, but they are a new technology that it's been development in the last years, and I think they have too much future. And what's the future? The really future is that we are going to have individualized treatment, assessment of individual healing potential, surrogate-based biomarker, patient-specific treatment, and therapy and diagnosis, therapnosis, as we talk in some chats. But the future, what we have to have is to decrease the accident, the traffic education, no chat and drive, use the safety belt, and no drink and drive. Decrease the accidents, improve vehicle security, as you can see with new technologies in the new cars. And what are our learning points and take-home messages? Advances in implant and technology. We have new soft tissue engineering. We have new material like polymers and surface treatment. We have bioabsorbable implants and individualized treatment. Thank you.
Rebecca will be able to.
Yes. Yeah. Am I audible?
Yes.
Okay. Thank you, Dr. Lozano. That was very nice. And now we are going to, without much ado, we're going to straight go into case presentations. And I'm going to request Professor Ed Harvey from Montreal to please give us a short case presentation. Ed is a professor of surgery in McGill University, Quebec, He is a leader of Injury Repair Recovery Program, McGill University Health Center Research Institute. Over to you, Ed.
Yeah, you guys okay seeing the slides?
Yes.
I want to thank everybody on the panel. It's been a very interesting debate so far. I was going to give a case example of proximal humerus fixation, but it's also a little oversight into orthopedic surgeons that want to be innovators and inventors. I've been successful in my own endeavors. I'm not going to talk about my implants, but I'm going to talk about Mike McKee's efforts in the proximal humerus in order to avoid any conflict. I actually spent 2 hours yesterday on the panel with the FDA in America about some devices we're bringing to market. So this is not an easy thing for orthopedic surgeons to get their head around, but if you want to invent, you have to. I think trauma implant development happens. We all think we're inventors. We are inventors. We modify things in the operating room on a daily basis and think, geez, I should really market that because other people could use it. And this is just sort of a little talk on how to do that. We do innovation in the operating room, but although there's a lot of types of innovations, most of our surgical innovation is just really about product performance, variations on plates and screws. I'm not saying that's not important. There's been a lot of important advances over the last little time, alluded to by other speakers. Locking plates, the TSF system, the tightrope are some of the biggest examples I can think of true innovation with new devices. However, most of our innovation is really around making a plate better, even though you think, oh, a robot's such an innovative thing. It's really about putting a plate on better. Gamma knife's was big. Implants are coming along, but most of these are really just incremental improvements. It's a really and it becomes a race to parity, basically, in most lucrative markets. So it's difficult for the orthopedic surgeon to do. Here's an example of a 78-year-old female who's retired, lives by herself, stable, comes in with this fracture. Everybody's sort of decided in their mind what they're going to do with this. Depending on what your toolkit looks like, you might do a hemiarthroplasty, you might do a plate, you might just do a sling, as the Proper study kind of advised us to. And it's up to each surgeon what they want to do, but we do know what the complications are with this. For a while, we all did proximal humerus locking plates. Good innovation, I think great innovation, but there are complications with it. So people have thought, how can we make this better over time? The major complaint was tuberosity escape. You can see, I think everyone's seen this in their practice. And if you look in the literature, about a little more than 50% of studies, of patients in studies show that there is some tuberosity escape. So surgeons have been thinking for a while, how do we stop this from happening? Suture is probably not adequate. The standard proximal humerus locking plates that first came out had no or poor tuberosity fixation just due to anatomy. And people have been innovating in the operating room. As I said, bent plates, using plates that were not designed for it. This is a plate that's designed for a web fixation, and probably insufficient for the proximal humerus. It's not going to go. I think people have come up with other types of fixation. This is one that Dr. McKee came up with. I have no financial interest in this device, but it had a part of the plate that would fix the head and wrap around the proximal humerus in order to prevent tuberosity escape. And they've actually brought this to market with an Austrian company, ITS, I believe, and are trying to get this adapted. This is a great example of a surgeon seeing there's a problem and adapting his practice and then asking a company to partner with them to get on with a better solution. It's a niche product. A lot of niche products are out there. I think they're great for surgeon innovation, Acumed screws, different types of plates. But I just caution you not to get into the example of innovation where you're just really putting a pink plate where a blue plate used to go. And it's very hard to sell. An example of maybe someone who went a little too far is femoral nails. Femoral nails first came around, was a great product, great healing rate. Came out with a straight nail back in the mid 1900s. It was a good product, didn't work all the time. So somebody said, I'm going to improve that. I'm not reinventing the wheel. There's a clear improvement. Proximal and distal locking screws in different directions. As Peter alluded to before, 2 screws in the head, 2 screws distal, came out with an incremental innovation that was really useful for most surgeons. So did we need an improvement on that? Well, people thought we did. There's a blow-up nail that came along. Thought that you could put it in easier and blow it up and have fixation with no locking screws, and really probably not the best innovation. It was published in the Nigerian Journal of Clinical Practice as its first publication, only mid-shaft femur fractures, and really had higher complications than the old nail. So this is an example of perhaps that clearly we've gone a little too far. Invention wasn't good enough in this case, but on the proximal humerus case I showed you, good example. We need to step through a logical progression when we're trying to innovate and have a market to bring an idea to fruition. And we need products with clinical needs. And if you can address a clinical need, you can get a product to market, and it has to have clear advantages over previous technology. I think that's a real take-home message for the surgeon that wants to be an innovator. Thanks for allowing me to share my ideas. Very Canadian slide.
Thank you. That was great. That was a very good concept which you brought to us. Now I'm going to ask Dr. Alvaro Zamorano from Santiago, Chile, to please show us one interesting case. Please go ahead, Dr. Zamorano.
Thank you. Hello, everyone from all around the world. I want to share a case that probably summarizes the concept of current demands and how the appropriate choice of implants can provide the answer for that. She's a female, 83 years old. She's diabetic too. Is a high blood pressure treatment. It's non-smoker, and she has a total knee replacement on 2011. She fell from standing position, and this is an isolated injury, is neurovascular intact, and the soft tissue is okay. It's unremarkable. So this is our problem. As Dr. Lozano says, we have a closer view of the problem. The elderly population has increased. She's increased the physiological demands, and he expecting of quality of life are increasing. So their demands are also more tricky for the surgeons. So we have to take care of these problems with the surgery. So this is the closer view of the problem. We are seeing a very small distal fragment of the distal femur with the proximal metaphyseal comminution. We can guess maybe which knee replacement design and type, and maybe we don't have any a lot of full sufficient answer of all the queries. So we have to complete the study, and we do perform a CT scan, and the value of the CT scan for us is to determine the critical metaphyseal area, so the planning, the definitive fixation, and sometimes we can answer indirectly which is the total knee and as an open box or not, and in that case we can see the scar of the cement. So we can guess that is an open box, is amenable to nail. So in the second question maybe is the loss of the component, and the CT can help us with that question. But for the literature and for us, the more important thing is there's no previous history of knee pain since the index surgery. So for us, maybe it's a good implant, not loosening. So we can go ahead with the fracture care fixation and not a revision of the surgery of the replacement. So to see all the problem, with the development of 3D CT scan, we can help to understand better how is the 3D of the fracture, and we can answer we can predict the demands of our implants. So we have to prepare our minds to good preoperative planning, to develop a good construct that provide early movement, and also all early weight bearing, because the elderly population maybe cannot be trusted to follow up the not weight bearing indications, and we have to, as a surgeon, we have to have this idea in mind. So I will share you my surgery with that case, and is in the supine position. We perform our anterolateral approach. So we did the reduction indirectly with traction, but also with open reduction of the articular zone, and we can see with traction how the fracture is reduced, and the metaphyseal area is gain the real length of the metaphyseal area, and we nail it. We nail from retrograded nail with open box. We start to pass our nail, and one thing to keep in mind with nailing is in those cases is the entry point is totally different for a non-total knee entry point. It's a little bit posterior, so we have to take that in mind. So maybe in some cases we have to change the implant, or maybe a tibial nail can be reutilized for this area. And also, as you see in the preoperative planning, the distal area it's a little bit short, so maybe a single implant maybe is not good only for that fixation. So we provide a hybrid construct. The actual data give us more confidence with the use of this kind of construct. So we use it. We use a polyaxial anatomic femur distal plate, and in combination with the retrograde nail. So we perform that kind of fixation, and also, as the literature say, we can mix both implants in one. So we interlock the plate with the nail, so we can do a more rigid construct, and also protect the femoral neck. In the elderly population is mandatory to protect it, and also we give more less strain in the combination area with two screws. So this is the final construct, the final hybrid construct, and that kind of result give us a lot of confidence to manage this kind of particular and demanding patients and also problems. And as you see, we can pass from this situation, and we can. Our goal is we achieve length, alignment, and rotation, and protect the femoral neck, and with the good hybrid construct that allows us early rehabilitation. So the challenge and take-home messages is the elderly population is an increased number of patients with an increased number of periprosthetic fractures. We need for an immediate weight bearing and range of motion, and we also have the problem with that we have to manage is the decreased bone stocks, maybe for osteopenia or for multiple surgeries. And also with a complete study, we can provide a good preoperative planning that is mandatory to choose the right implant to allows us to complete our goals. So thank you, everyone. That's my case that I wanted to show.
Okay, thank you, Dr. Alvaro. That was an excellent case, and this is what we've been talking about. Implants are now collaborating. We had a case where in the distal femur or in the entire femur, we had a nail, a plate, and a prosthesis. So that is true collaboration of implants helping the fractures to heal. So for this evening, now we have our last case from Dr. Sasinder, our live wire moderator from Oman, who has really been a big force behind this entire webinar. So may I request Sasinder, please show us your case.
Yeah, thank you very much, Dr. Arinda. Before I go on to my presentation, can we have one question? We have one question. Does it make a difference if the raft screws are placed through the plate or outside? Can I have,
okay, I think Ed has already answered part of the question, but if you could just repeat it for the audience, Ed.
Yeah, I think if you look at the data, actually from the AO group, the raft screws are important, maybe possibly important in type Cs, but not important in type Bs to go through the actual hardware.
So it depends on the fracture pattern. Basically, I think there's no rule, but you have to play it by what you see on the X-ray or the CT. Any other comment from anyone else? Peter?
Raft screw, now we have the raft plate. So through that, you can put the raft screws. So that is a modification of the
yeah, it's I think it's a modification to ensure that the screws are actually adequately spaced and also aiming in the correct direction. I think most of us who are senior surgeons might not need it because we didn't have that technique before, but it's a good technique for neurosurgeons, yeah.
That's right.
Yes.
Any other
I think
comments?
important is that that you use these screws in the metaphyseal area. If you use it in the diaphyseal area and you put a leg screw through a swinging plate, this sometimes gives not so good results.
But a raft screw is always subchondral, no? It has to be subchondral. A raft, it's like a raft of a roof, so it has to be below the roof. Yeah.
Okay. Sasinder, can we just put one question? I just have a question to my panel. Quickly,
Yes.
Professor Shetty, if I can start with you. What do you think in the last 25 years in upper limb surgery, can you select one inflection point for implants? I will ask everyone this particular question in the panel if we can.
Now, beg your pardon again? Beg your pardon?
One inflection point where there's been a drastic change, like a mutation of implants, something which has changed dramatically in the last 25 years in the upper limb. If you were to choose one important change, what would it be?
No, it is the anatomical plates. I would say it is the anatomical plate, whether it is the clavicle. So clavicle, we used to fail in fixing of the clavicle because we used to use all the straight plates or the DCP plates. Your clavicle is a very cylindrical bone to a quadrangular bone as it changes and a curve. Unless it is anatomical, it doesn't. Take the humerus per se. Humerus is a very complex bone with the proximal the ball and socket joint and a pivot and a hinge joint below. So it is the torsional strain is so much. So whatever implant, it has to be anatomically fixed. If you put a very rigid plate, it is likely to fail. That's why the failure rate is much more. Take the lower end of the humerus again. The column plates are so well made now. The lateral column is so good that it goes to the lateral condyle and it maintains. And the screws are put diagonally so that it really fits in so well. So it's the anatomical plates which have made a difference.
Great. Ashok, in pediatrics, what would you say is the singular most important change in your opinion in the last 25 years?
Well, basically, it's a shift. It's a mindset shift, and philosophy change from non-operative to operative. And this is largely shown in managing long bone fractures, and titanium elastic nails, I think, have a big contribution in it, because they're minimally invasive. So it's minimally invasive, relying on the body's biology, the child's biology and remodeling potential, So if we can do a sort of minimally invasive surgery in a very small time, without disturbing the biology and get the fracture to heal with a reasonably good alignment, I think that's a major shift which has happened or a major inflection point.
Okay, great. Same question to Dr. Lozano. Your opinion, singular most change you feel?
Yeah, the anatomic plates with angular stability. They change our mind. They change the fracture treatment, and articular fracture that in the past has a lot of problems with that technology is now more easy to treat.
Okay, great. Peter, same question to you. Peter, singular most big change you have seen in 25 years, something which has changed the direction of implantology.
In the past 25 years, I think the most important issue was the development of locking and polyaxial locking devices.
Okay, okay. So, Sindhu, do you want to comment on this? And maybe then...
I think the speakers have covered it all. I would agree that the innovation of locking plates and subsequently the anatomical locking plates have a very important role with respect to fracture fixation, and the way the fracture fixation has gone ahead, and anatomical locking plates has allowed us to progress from less biological fixation to more biological fixation. I think that has changed a lot of ways in which a lot of fractures have been fixed, and have also changed the indications for a lot of fractures. I would agree with that. And maybe the same question with respect to innovation, Dr. Ed can talk about what direction in innovation has happened dramatically over the past few days.
Yeah, I could probably, I know that anatomical and locking plates are really important in my practice too. I'm an upper extremity surgeon, so the whole thing with distal radius plates is big, but I think the biggest thing that's come along is this innovation package with process and device. For me, when I was a resident, my chairman told me he didn't trust anyone who operated on a bone that he could eat. So if you thought of fixing a scaphoid in his OR, you were dead meat. So I think that all the innovations allow us to work on the hand and allow early range of motion in 5 days has been huge, huge effort for workman's compensation, especially. So headless locking screws, small plates, small custom plates, and the whole package that went together to allow us to do that, I really have enjoyed.
Okay. Alvaro, your comments?
Yeah. If I can add something, as you said, at least all, but also how we can change our knowledge on and how we can understand more the fracture necessity. So we can develop a good strategy. We can develop a good preoperative planning, and how to make a hybrid construct, or the necessity of something like bone allograft or something. But for me, the understanding of the fracture, it's the most important knowledge in the last few years. Maybe the implants not so important, that how we can understand more the fracture.
So there is a question from Jim Waddle to Ed, and the question is the importance of an act for any new implant for proximal humerus.
RCT.
So that's the question.
It's supposed to be RCT. What is the importance of having an RCT for any new implant for proximal humerus?
So great question, Jim. Thanks a lot. I think a lot of the problem with the perception of fixation of proximal humerus fractures is compounded by a couple things. The literature that goes before the Proffer study has some well-publicized weaknesses, but remains sort of the gold standard amongst many administrators for what you can do with the proximal humerus, as well as the recognition that a lot of the things that happen in the proximal humerus are reliant on soft tissue injury and not just the bone. I think it's really important that we do a proximal humerus randomized controlled trial, but we have to find the right implant and the right implications for doing that trial. But great question.
Yeah.
The question is, if we want to do an RCT, are we comparing like with like? Like if you have fractures from A11 to C33, and then it's very difficult to get the numbers for every different type of fracture with every different, if you're comparing the different implants. So I think it's very difficult to actually do a RCT. You can do a basic RCT perhaps between comparing a nail with a plate or a specific type of a plate with another type of plate, but doing individual variations, I think getting the numbers is going to be extremely difficult. Other questions from the panel?
Can I add something? Can I add something?
Yes.
I think there are several indications where prospective RCTs in surgery have not proven that it's better. So if you think of the forearm fractures, distal radius fractures, and the proximal humerus too, the problem is that if you create a RCT in this type of fractures, you create a artificial world, because as we all know, surgeons are used to one implant, and if you randomize the surgeon to another implant, probably it's clear that this result might be variable. Hence, in the theoretical science, there is a tendency to go to big data analysis of big retrospective studies. So my suggestion is that since we are all international trauma surgeons, let's start a big data registry for proximal humerus fractures. I can send you electronic patient-reported outcome measurements, which you can let have your patients be filled in the waiting area, and you can gather all of this data electronically. So we will get big numbers in a very fast time.
Yeah, ours has started actually. So I'm a founding member of COTS, Canadian Orthopedic Trauma Society. We've had an ongoing debate about the proximal humerus over the last 20 years. So somebody gets up at every one of our meetings and tries to refine a study for a proximal randomized control trial, and we have not been able to do it. So Emil Shemitz actually started a big data kind of prospective cohort. We just take everyone and we're going to analyze it afterwards. It's a good point. It's really hard to do.
Can I just add on proximal humerus is a fracture which is so variable, from fracture to fracture dislocation to anterior to posterior to three-part to the split fracture. So a randomized study is extremely difficult to really evaluate a particular type of fracture with the type of implant. So you will have to see the type of patient, the age of the patient, the bone's texture, the type of fracture. So a randomized study will have to include all that to really. We will, as it was rightly suggested by Peter, it is worthwhile doing a randomized study internationally, so that compartment-wise we will study that.
Okay, there is a question to Ashok, which is, how much deformity and displacement can you accept in a pediatric fracture of the radius, radial and ulnar shaft?
Thank you, Arindam. Basically, I think what this question has to be more specific in terms of the age of the patient. That is important for remodeling. In terms of the location of the fracture, whether it's the mid shaft or whether it's towards the physis, because you can accept bigger displacements and bigger deformities as we go nearer to the physis, and more it comes to the shaft, the incidence of remodeling or the amount which is acceptable sort of malalignment, reduces. But having said that, because the forearm is involved in pronation and supination, we really don't accept a lot of deformity. Maybe a 10-degree deformity is acceptable in the mid shaft, But if the child is young, if the child is near to skeletal maturity, is a different situation. If the child is maybe 8 or 9 years, he's going to remodel that very beautifully, So there are tables which are available which actually tell us, how much of remodeling can be accepted at what ages.
Okay, thank you, Ashok. So we are planning to wrap up in about 5 or 7 minutes. I'm going to ask Sasinder to show us his case, which he has kept for the very end. You can show us your case.
Thank you very much, Dr. Arindam, and thank you very much, SICOT and SICOT Pioneer, for this opportunity. I'm going to discuss a relatively simple case that most of the trauma surgeons are going to see every other day. This is a 22-year-old female who presented with pain and swelling in the elbow after a fall from the bicycle. She presented in the emergency room. She was left-handed and she has injured her left side. The X-ray, the best X-ray that could be taken in the posterior and lateral views. And we'll also show the CT scan 3D reconstruction. So we know that we have articular fracture and that is comminuted. So my question to the speakers is, how would you decide on the treatment for this patient? Would you go ahead with a cast? Will you prefer an open reduction and internal fixation of K-wires, or plates and screws without osteotomy of the ulna for exposure, or if with plates and screws with a better exposure with ulnar osteotomy?
I take 4.
Okay. Thank you, Dr. Peter. Can Dr. Shetty, you have some comments?
Yes, with the trap exposure, you can do even without an osteotomy. It has to be a bicolumn fixation.
Yeah, I agree. This is what I do in my practice. I do a lot of these. I have not done an osteotomy in 15 years.
Okay, Dr. Lozano, this is Dr. Lozano's patient, so I'm not going to ask Dr. Lozano. And Dr. Alvaro?
4. It's osteotomy for me.
Yeah,
Okay.
for me, osteotomy too.
Yeah, okay. Dr. Lozano's answer is biased because it's his patient. Okay. Okay, fine. So this is what was done for patient. So posterior approach was taken. Ulnar osteotomy was done. Ulnar nerve was exposed and isolated and protected. The distal humerus was exposed, and anatomical reduction was done because it's a comminuted fracture and it's an interarticular fracture. And now the evolution of plates comes into picture. We have more and more anatomical plates, and we have locking plates which give better fixation even in more osteoporotic bones. And this is the postoperative picture. Now, a question to the panelists again, and it is also related to the question that we have received from the audience. What is your opinion about orthogonal plating? How much of importance do you give for orthogonal plating in distal humerus comminuted fractures? Or do you prefer parallel plating? What is your opinion, Dr. Shantaram Shetty, please?
Orthogonal plating is much better because
why not parallel plates?
Parallel plates, it has been, all the studies have proved that the more the combination, the columnar fixation is quite important. Columnar, both sides fixation, because the anatomical plate really is shaped in such a way that the column and your screws on either side go crosswise so that they fix all the fragments. Whereas when you put a parallel plate, your screws will not be holding all the fragments. There is a possibility of
Dr. Peter.
I personally prefer the 90 orthogonal position. However, I think this depends a little bit on the experience of the surgeon, and I'm pretty sure that you can also solve it with a parallel position. This is more depending on the experience of the surgeon with his implants than the principal placement of the plates. It's possible in both orientations.
Yeah, I agree with Peter. It's important to get bicolumnar, but depending on the fracture pattern and depending on if you want to retain the muscle attachments on the medial side, you might not want to strip off as much. You can always use the posterolateral plate from the opposite elbow on the back of the medial side, and it gives good fixation distally. And I'd encourage everyone to explore the trap flap for exposure. You get 96% of the joint exposure without doing an osteotomy.
Can I, about the osteotomy part of it, can we have a discussion a little about the osteotomy? Yes, osteotomy is required or not? Because nowadays we do not do the osteotomy at all. Unless it is very, very badly shattered, it's required. Because the complications of osteotomy are much more.
Plus, you muddy the waters for your total elbow arthroplasty if you have to do one later for arthritis, or if you're going to do any kind of dermoplasty for the elbow for a young active laborer, you'd rather not have the osteotomy in place when you come along to do it because you've already sacrificed blood supply.
Okay, Dr. Shantaram Shetty, because you pointed it out, is there any situation when you would like to have an osteotomy, like any specific fracture type in the distal humerus, you'd like to have an osteotomy?
Yeah, where you want, where there is an anterior component, it is a sagittal plane, just like the capital lumbar fracture which has gone off, where you may not be able to, with the trap, you are not able to really see those fragments. Then it is better to really reflect the whole olecranon and see the whole thing as a whole, as it was done there.
Okay,
the other
Dr.
important
Pete.
thing is the reconstruction of the osteotomy with this hook plate is actually quite a step forward, because in the past, with all those tension band wirings and the large screws, you ran into all sorts of problems. But this hook plate is excellent. I think it's a very good situation. So,
okay, Dr. Peter. I'm sorry, yeah. Dr. Peter. Now that Dr. Shantaram Shetty has pointed it out, what message do you have for the average trauma orthopedic surgeon? I know you're all experts in the field. If it's an average orthopedic surgeon, what would you suggest? You'd like to have a better exposure with olecranon osteotomy, or train them for non-osteotomy distal humerus intra-articular fracture surgery?
As I mentioned, if you are not doing only these type of fractures, then it's probably safer to go for an osteotomy to be sure that you reduce all of your intra-articular fragments properly. And since Arinjam told already, I also personally prefer plating in the olecranon fractures very much, and we came completely off from the tension band wiring.
And one last comment to Dr. Shetty. Do you have any tricks for avoiding an olecranon osteotomy but have a good anatomical fixation of the distal humerus fracture?
No, we decide on the CT basis whether you want to do an osteotomy, whether other. So majority of the fractures will not require an osteotomy at all. So a CT will really tell you whether the three-planar, the three-dimension will really tell you where the fragments are and how difficult it will be to reduce back into position, especially
what
a
about
sleeve type of.
Sasinder, I think I'll just cut in here. I think Vikas is getting looking fierce over there, so I think we'll have to finish the discussion here.
Yeah. So that was a wonderful discussion.
Very good evening from Calcutta, and it was, I think, a very nice discussion, and I think we've all learned a lot. Very exciting to hear from colleagues from all over the world, and I hope we can do it again in another form, maybe bit by bit, part by part of the body in some other forum or here. So I will leave it to Vikas to now wrap up the show.
I'm sorry, I would like to just share my last screen. So the take-home message is: know your fracture properly, assess your fracture properly, and know the options that are available, know the indications, and know what you should not do. Know the contraindications. You should know the technique before you venture into it, and you should know whom to call if you want to plan something complex. So thank you very much, SICOT. Thank you, SICOT Pioneer. Thank you, Vikas, and thank you, Gau, for this wonderful opportunity. Thank you, Dr. Arindam, Ed, and all the speakers. Thank you very much for the wonderful opportunity. And there's lots and lots of more opportunities coming up in SICOT. Don't forget to join for SICOT Pioneers' next program, Rising Within an Orthopedic Society, Learning from the President. It's going to be a wonderful program. I welcome all. And over to Vikas.
Just like to formally thank all the speakers and the moderators from SICOT Pioneer. It's been a lovely afternoon here in the UK. I'm sure probably evening or morning for you guys all around the world. It's fairly clear that with the discussions based on the humerus and the elbow, we need to probably do specific webinars for each joint so that we can discuss all the nuances of fixation and appropriate management in these. And we'll certainly try and arrange that. So once again, from all of us at SICOT Pioneer, thanks to all the faculty, thanks to the moderators, and thanks to all our viewers around the world who tuned in. Thanks a ton. Thank you.
Thank you very much.
Thank you. Thank you.
Thank you.